Welcome to the NewlyMeds podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
What is up, guys, and welcome back to another edition of the NewlyMeds podcast. Dan and I are super excited for this episode today, and we're really stoked to have you guys back after a little bit of a spring break that we took. So, Dan, today I want to pose a little bit of a question your way for our QuikCrit. You have a patient and you see a wide QRS. They're not doing too hot, and they're kind of circling the drain. You maybe infer, or you have an I stat on your ambulance, or you're in a hospital setting and your potassium is 7.2. What are some things that you want to do with this hyperkalemia and why? And I think that's kind of the pathway we're going to be discussing today. So Dan, why don't you tell me a little bit more about what you're thinking just based off that real brief intro?
Well, yeah, absolutely. From a pre-hospital standpoint, definitely want to make sure that I am watching the monitor so we can look out for any type of ECG changes from a hyperkalemia standpoint. And then I also want to be thinking about calcium. And you're right, Will, like when we start talking about this episode today, we're going to kind of get into the calcium side of things, why we're giving calcium, how that's working in the hyperkalemia patient, and what it is and what it actually isn't doing for that patient. Now, obviously, you know even better than I do, Will, when it comes to the hospital setting, some of the other things that we're going to be looking at for this patient. But primarily for this QuikCrit, we want to be looking at the calcium and how we're going to be able to potentially immediately affect change on these hyper-K patients from a pre-hospital standpoint with calcium.
Absolutely, Dan. And I think that calcium is one of those medications that we can give in the field that might have some benefit, but it is very situation dependent. And so I want to get a little bit into how calcium actually works on the body. And so when we think about any cardiac medication, any cardiac patient, I've always said this, and Dan, you and I have gone back and forth multiple times in our room. I think that you always should have a cardiac action potential right next to you, because that's a really good way to understand how these medicines work, because you're going to start talking about thresholds, different electrical changes that are going on. And so seeing that membrane potential, that action potential, really helps to understand how these medications work. So at a core value, calcium is going to raise our threshold potential, that resting membrane potential. And so when it does that, it's not really going to change the direct potassium level, but it's going to shift our action potential upward. And so because of this, our gradient is going to shrink. And then the difference between our resting membrane potential and the threshold potential allows our sodium channels to function a little bit more normally. So that's a little bit high terminology, a little bit sciencey, but what does that actually mean? Well, you hear this term all the time in EMS, and I think it kind of gets thrown around really without diving into the deep meaning. Oh yeah, we give it because it stabilizes the membrane potential. Oh, we give it before bicarb because it stabilizes the cardiac cell. Well, yes, absolutely. But what does that actually mean? Well, it's going to improve how that cell actually synchronizes and depolarizes when we're giving it. So we want it to kind of beat at a certain time all the time. That's what a normal sinus rhythm is. We have these beats that are very reliable. They happen the same time, 70 times a minute, whatever it is. And then it's going to reduce the risk for us to enter into a lethal arrhythmia. So as we start to shift some of the electrolytes, like if we were to give sodium bicarb or even the calcium, and some of that potassium inflows or outflows, as those electrical changes occur, it decreases the risk that we have for any arrhythmia because we are raising and shifting that potential. So we're reducing the risk of entering into a lethal rhythm when we give this calcium. And so it's good to remember that in the field, we're giving calcium chloride compared to something we give in the hospital quite frequently, the calcium gluconate. And 1 gram of calcium chloride gives you about 270 milligrams of elemental change. And so that's 3 times more than the gluconate. And essentially what that means is that this calcium chloride is going to react a lot faster in the body, and it's going to strengthen the membrane a lot more than the gluconate. So we're going to see this in our peri-arrest or actual arrest patients. It takes about 1 to 3 minutes to work, and it lasts for about 30 to 60. And if you have that patient that we talked about earlier with that wide QRS, you're going to start to see it narrow. So that's a little bit about why we are giving the calcium. But Dan, why don't you tell me a little bit about when we're not giving it, what calcium doesn't actually do for us, and then the role on a real patient encounter?
Yeah, absolutely. And I think it's important that we also talk about just a little bit more on the action potential there. Will, you did a great job doing that. But when we're looking at the standard normal physiology of the action potential, when we're looking at that membrane potential, a normal heart, we're going to have that large potassium gradient. We're going to have high intracellular potassium and low extracellular potassium. And that's going to give us a strong outward potassium shift, leaving us with a very negative resting membrane potential. And when we're looking at a hyper K patient with that increased extracellular potassium, that's going to reduce that gradient, which means that less potassium is going to leave the cell, which is going to make that resting potential, that resting membrane potential, less negative. And when we have a less negative resting membrane potential, that's going to ultimately affect our fast channels for our sodium channels, right? That negative resting membrane potential is going to cause more of the fast channels to stay inactivated, and that's going to then leave fewer available for depolarization. And that's why when we're having less activated fast sodium channels, that's going to cause those physiological changes that we're seeing on the ECG there. And so again, when we talk about, everybody knows the phrase that's pounded into your head in paramedic school, you know, that it's, we're stabilizing the membrane, we're stabilizing the cardiac cell, right? That's why, because that effect that it's going to have on the potassium shift there, that's going to help reactivate, if you will, some of those fast sodium channels. And so when we're looking at that, yes, we have these hyper K patients, but when we start looking at our protocols and when we start looking at patients that we're typically giving calcium the most, or at least considering giving calcium the most, is what, Will? It's our PEA arrests, right? And when we start considering calcium in a PEA arrest, again, another thing that we've had kind of pounded into our heads is our H's and T's, right? And I know one of the first things we want to think about is our hyper K patients. Is this a hyper K arrest? And if so, are we giving calcium for that? But when we look at it from a physiological standpoint, why a true hyper K arrest, why hyperkalemia causes PEA in the first place, is exactly what we were just talking about with that cardiac action potential, right? That's going to slow the conduction. We're going to have either weak or completely ineffective depolarization. Our cardiac contractility is going to be weak or absent as well. And that's why we're going to get that PEA, that we're going to still have the electrical activity, and it's going to typically come in the form of either a wide PEA or something similar to a sine wave, right? But when we start thinking about calcium in this specific scenario, the goal of giving that calcium is the same goal as when we're looking at an alive hyper K patient, right? We're trying to improve that conduction velocity. We're trying to kind of restore that electrical coordination and give the heart a chance to have a better mechanical contraction. But this is only going to help, Will, right, if it is a true hyperkalemia arrest. And even then, if we start looking at some of the studies, which again, we always link in our show notes, and we always recommend that you guys go read these studies for yourselves. But Will, something that I found kind of interesting looking at these studies after paramedic school, when I thought calcium was going to be the life-saving drug, right? And everything was going to be great if I just give them some calcium. Why don't you walk me through what we are seeing in these studies?
Yeah, Dan, absolutely. And I think something that I learned similar to what you just said is after paramedic school, we kind of realize how, I don't want to say bad we are at paramedics at doing certain things, but maybe how not educated, but unknown of the actual research that's out there on why we do these things. And that's the whole reason we established this podcast. But you're right. These studies actually say calcium kind of sucks and we're not really using it appropriately. So the first studies, they looked at PEA arrests at a really basic area. It saw that ROSC was lower with calcium, about 20 to 30, 40-ish percent, with a lower 30-day survival and no benefit, even with EKG patterns that support hyperkalemia. And then a second study also showed that there was no real overall survival benefit and that there's actually maybe some harm that we're doing with the calcium use. They did see a benefit with true hyperkalemia, and obviously there's some benefit with our calcium channel blocker toxicity. If somebody has those calcium channels blocked, we got to give them that calcium back. Oftentimes those patients are requiring pretty high doses as well, not the doses that we're carrying on the truck. So that's a good scenario to think about when we're calling for maybe some additional resources. To dive into these studies a little bit more really quickly, and I would urge all of our listeners right now to go back and look at them. I always make it a point to look at, why does the data in these studies really show what it's showing? Is the mortality bad because these patients were really, really sick? Obviously, they're in cardiac arrest. And so is it a true reflection of the medication doing its job and hurting the patient? Or is this a reflection of something else? And I think that's where you really have to read between the lines in these studies. It's interesting to note that there was worse neurological outcomes in this second study that was a systematic review in 2022. You can kind of make sense of that because of how calcium affects the neurons. This is a little bit even out of my realm. As a street paramedic and a cardiac ICU nurse, I'm not really the best at neuro things. I would really refer you to a neurologist or a neuro nurse, somebody who does this all the time. But I am aware of how calcium kind of influxes into the neurons and creates these free radicals. So I could make sense of the worst neuro with the calcium and how it could create harm. And then in the first study, I do think there is an argument to be made for the sicker patient study. These are patients that are in out-of-hospital cardiac arrest, differing populations, differing strategies. And so looking at these studies, maybe they're saying calcium's bad just because of the patients that are in there. Excuse my dog there in the background. So I do think there's the case to be made on, how sick are these patients and what's going on. I think that understanding the patient population that gets the calcium is so critical. I think in arrest that patients who are getting calcium, it might not be the best idea. But I think the patients that are truly having a hyperkalemic emergency and are peri-arrest, I think that is a great population subset to administer pre-hospital calcium. And I would refer a lot of our viewers back to an episode I did with Dr. Myers months ago on a patient that he saw in the field that he gave calcium to and why it was so important. And that patient was not in arrest. And really, it was the intervention that prevented a negative outcome with the cardiac arrest. So Dan, while I come and let my dog in here, I'm going to throw it back to you to kind of explain when and why we should be using the calcium and why it's so important.
Well, yeah, and I think you made some really great points there. And I think one other thing that I wanted to point out from the COCA trial, which was the calcium went out of hospital cardiac arrest. So in the COCA trial, it stated that essentially that we are not the trial is not supporting calcium administration based solely on the ECG findings. So essentially, if you don't have a lab value and know that it was hyperkalemia prior to arrest, leading to the arrest, essentially they're not supporting that, because not only were they not seeing positive outcomes, they were seeing potentially negative and at times negative outcomes from the calcium administration from that. So when we think about that, exactly what you said, we want to, when we're considering our H's and T's in cardiac arrest, obviously we know a crashing hyperkalemia patient when we're looking at that from a clinical aspect. But when we're thinking of our H's and T's in the arrest setting, when are we suspecting that it is a hyperkalemia arrest? And again, based on what the trial is saying, we're not necessarily using one of these pieces of information as a confirmation that it was a hyperkalemia arrest. But if nothing else, this should be raising our index of suspicion, right? So our renal failure in dialysis patients, somebody that missed dialysis, a potential crush injury that leads us to think rhabdo, or even some type of urban crush syndrome, which maybe we can talk about, later at another episode as well. Our potential DKA patients, ACE inhibitors, or other potassium sparing medications, anything in which that's going to cause that increase of extracellular potassium, right? And again, those supported ECG clues being the peak T waves and the wide QRS, a Brady rhythm, right? But again, we're not necessarily making that final determination based solely on those ECG findings, right? We need some type of increased index of suspicion that it was a hyperkalemic arrest and not just something that we're seeing after the fact due to the fact that the patient is in arrest. And some of the other things, Will, if you want to talk about these as well, but some of the other definitive therapies when we're really trying to look at pushing the potassium back into the cells, right? We've talked in the top of this episode where we're not, giving the calcium is not doing anything as far as shifting the potassium. Again, to use the cliche, we're stabilizing that cardiac membrane, right? So when we want to look at these definitive therapies, we're looking at the insulin and dextrose administration, and we're looking at albuterol, and in some select cases, maybe some sodium bicarb. But we're looking at something that's going to actually shift that potassium from the extracellular space to the intracellular space. But again, the key takeaway, as Will already pointed out, the key takeaway from those studies ultimately is that we're not just giving calcium blindly in all arrests or even in all PEA arrests, Y complex PEA arrests. We need to actually have context and a sound logical reasoning as to why we are giving that based on the suspicion of it being a hyperkalemia arrest.
Absolutely. And Dan, I think what you just said rings really true to me. And I'm just going to hit on it from the EMS world, because obviously the biggest bang for your buck with shifting potassium is going to be your insulin. That's going to do a really good job. The dextrose, everyone says insulin and dextrose. The dextrose is just because with the amount of insulin that we're giving, we're going to make somebody hypoglycemic. So we're trying to buffer that out. But insulin's really what's driving that potassium back into the cell. But as far as EMS goes, making sure that we are giving the calcium before the sodium bicarbonate is critical. The sodium bicarbonate is going to shift our potassium if our patient is in that acidotic state. It's going to help buffer that. But it really just masks the issue that's going on. And we have to remember to treat that underlying issue. If that issue is hyperkalemia, when we say we're stabilizing the cardiac membrane, calcium is raising that membrane potential so that our sodium potassium pump works efficiently again. And so if we're going to try and get stuff in and out of the cell, and we don't have a pump that's working to do that because we never gave the calcium and we're just throwing bicarb at this patient, are you maybe going to see an increase in blood pressure for 3 minutes? Yeah, probably. But are you just masking the overall issue and not correcting it? Yes. And so that's when in the field, give that calcium, give it a couple minutes to work, see how your patient does, and then maybe give the bicarb if you're needing it. But you may realize you don't even need it at that point, and then getting them to that definitive care. So always treating that true underlying cause. I think those are the huge clinical pearls with calcium. We have to remember that it's not going to shift the potassium a ton. It's actually just helping that membrane, like we just talked about. It may narrow that QRS if you're seeing a really wide QRS. And I think critically too, understanding your H's and T's, but in your current arrest patient, don't always assume that PEA arrest is hyperkalemia. Make sure we're giving the calcium when it's appropriate, and try not to get those blinders on. It's so hard in EMS when you get, a patient in arrest at the dialysis clinic to not throw up the blinders and think one thing, but try to take a step back, look at the whole picture so that we can really choose appropriate interventions that are patient specific. And that's the hardest thing to do, because I think when we start talking about patients as a whole and therapies as a whole, we kind of lose that big picture And we got to keep that in mind in the field. Dan, you have anything else for me while we wrap this one up?
No, I think you hit the nail on the head right there. Again, just keeping in mind, some of the things that we're looking for, whether it's the peri-arrest or the arrest patient. But when we are giving calcium, obviously we're wanting to look for if that has any effect on what it is that we're looking at. And one of our biggest, unless you have an iStat or the ability to follow up on the actual potassium level, one of the biggest things that we'll be looking for would be those ECG changes of back to a narrowing of the QRS. Again, the opposite of what we are looking for, obviously, in our hyper-K patient, right? So do we see any improvement in the ECG findings there? And other than that, I know that I'm just excited to be back and giving some quick heavy hitter little episodes here in the QuikCrits, and we'll be back into the more in-depth heavy topics for our next episode next month, coming back out on the 1st of May. And I know I'm excited for that. But otherwise, make sure that you are following the socials. We're getting very close to having that new series out. You'll be seeing some more information on that coming out soon. And otherwise, I think, Will, you have anything else?
That's it for me. Thanks, as always, guys, for listening. Shout out to my dog. She really wanted to be a part of this episode, so I apologize about her. But we'll catch you on the next one.
See you guys later.